going to have a very good case presentation, case series, mainly on a very common pediatric topic. And this is a topic of interest to all our general practitioners as well as all the physicians, and from pediatrician perspective, this is one of the very hot topic. The first one is urinary tract infection, and the second is nocturnal enuresis. And this is one of the very undiscussed topic, nocturnal enuresis. Most of the things are still not known, and today we have got the most expert speakers who are going to give us the latest insights about UTI as well as nocturnal enuresis. To keep this topic very simple and lucid, we have taken this as a case presentation, and I am going to ask questions as per the case, and we have got the experts who are going to guide us as we go through. So without wasting much of our time, let us start with the first case. This is a 7-month-old male child, infant, born at term, had uneventful perinatal period. Antenatally, the ultrasounds were reported to be normal. Now this baby, very well grown, comes to us with high-grade fever along with chills for 2 days. Mother says he is continuously vomiting on and off since last 2-3 days. Child does not have any other respiratory complaints. There is no other gastrointestinal symptoms as such. Urinary stream appears to be normal. There is no dribbling. And on examination, this baby has 103 Fahrenheit temperature with no obvious focus. And there are no other signs of dehydration or meningeal irritation. Enteral and fontanelle looks okay. Now this is a case of fever without focus in an infant. The initial reports of this baby showed WBC count of 25,000 with polymorphs 85%, CRP was raised, and blood cultures were awaited. This was the baby who was admitted in a hospital, and now the question goes to the audience. What do you think? This is a child, this is an infant who has presented as fever without focus and has got polymorphonuclear leukocytosis. So what questions, what things go to our mind? What are the differential diagnoses?
There is obvious septicemia.
Okay.
But first thing, urine, you should start with urine examination first.
Urine examination.
Yeah.
Okay. So rather than going for a WBC count,
First you start with urine.
Urine. So your first diagnosis is UTI or sepsis.
It may be viral, but usually we start with urine examination, then we'll go for blood test.
Okay. So as Dr. Dhalte pointed out that first you would like to do a urine test. So definitely in this case, since most of the things are said that there are no meningeal signs, there are no signs of gastroenteritis, there are no signs of respiratory tract infection. So any infant with fever without focus, we should think of UTI. So what are the next steps? What should we do in this case? Since we have done a blood test, now as Dr. Dhalte said, urine examination. So the most biggest challenge in pediatric practice is collecting urine. Now how do we collect the urine of this child who is an infant? What are the ways? How do we in our day-to-day OPD advise mother how to collect the urine? Because she is also, most of the time it has happened. We have advised urine routine test, and after 48 hours mother comes with only hemogram report. She doesn't show the urine test, and then when we ask, she says it's very difficult. I could not collect the urine. So any comments on collection of urine in a pediatric population? So methods of collection, which is the commonest method? What is as your experience in your day-to-day practice? How do they collect?
Most of them actually we do random collection.
Okay.
Most of unscientific methods we follow.
Yes.
But
so I have seen most of the mothers, they see that the urine lies on that diaper areas, or it lies even on the glass or on the floor, and they try to collect urine in that fashion. So that is something which is obviously a very wrong method. The second important method what we have seen very commonly, they put some bag. The urine is collected in that bag, and then they pour that urine from the bag into the container. So that is a very second common method how it is done. And in girl child especially, it is extremely difficult. So now the question goes to the expert that this is the common way how urine is collected, and what do you think these methods of collection, is it going to really affect the diagnosis? Is it really going to affect the results what are going to come? So what are your comments on this?
So for the collection of urine, for the routine microscopy, it's okay if they collect it like from the bag also. The most important thing to remember is when you're sending for culture, the method of collection becomes very important. Because once the urine culture report comes, very rarely do we ask the parents how have the urine been collected. We just see most of the times we see the reports, and in the busy practice it becomes difficult to ask how the urine was collected and whether that growth which is shown is actually the true growth. So for urine routine microscopy, it doesn't matter how the urine is collected, but for culture, in an infant especially, collecting it through urobag is not recommended. In a paraneonate or in an infant, if it becomes difficult to catch a midstream sample, it's advisable to either do a suprapubic aspiration, which is actually rarely done, but it's a very safe procedure. The needle is inserted just 1 centimeter above the pubic symphysis. But one thing which you should remember is just by that stimulation, by the needle stimulation, the baby might pass urine. So keep a container ready, handy, so that if the baby passes because of that stimulation, and many a times one very good method is you can ask the mother to use an ice wrapped in a cloth and just put on the bladder. So that also stimulates the bladder, and just keep the container handy. So that is the way they can collect the sample. But very important to remember is never collect, always inquire about the method of collection of urine, especially for the culture. And if the baby is admitted in a sterile manner, you can do in and out with the catheter using an infant feeding tube. Just go in, collect the sample and come out. So these are the methods which can be used for urine culture.
And for urine routine also, actually, for if they collect from the fecal
of course,
contamination.
they should not collect it from, many a times we also ask, they make the baby lie on a Macintosh and they collect it from, not that, but of course, just urobag sample can be sent for routine microscopy.
There was one study published in the BMJ for collection of the midstream urine sample for the babies less than 3 months of old. In that, what they did is, you give the feed to the child,
right,
and after feeding, after 30 minutes of the feeding, you need to tap on the bladder with the forefinger at the rate of 80 per minute, and again at the back. So they found that within 30 to 45 seconds, almost 80% of the babies used to pass the urine, and you can collect the midstream sample.
So any way of bladder stimulation they can use and collect the urine. Yeah, that is very important, especially after the feeds, because sometimes after the feed, let's say half an hour after the feed, the bladder will definitely become full.
That is one of the maneuvers. The other one is starting the tap water. So just if you start the tap water, that flow of the water, even that also stimulates the bladder. So that is another way how you can do a maneuver for starting the urination process. So from what Madam narrated, this urine bag collection is not a standard practice for collecting the urine for culture process. Either we can do a midstream clean clutch, or we can go for hospitalized patient in and out catheter. That is one of the very easy thing to do. And somebody who is really specialized, he can definitely go for suprapubic aspirate, which is not a very difficult procedure, what Madam has pointed out. Now another point here, why we say the method of collection is important, because when we are going to get the culture reports, then that colony forming unit is different for different method of collection, and that is why this method of collection is to be known, and then only we can comment on the report. So this child, the catheter in and out sample was done because it was a hospitalized child. WBCs were 25, as we said, in the urine with per high power field. There was bacteria positive. This is very common report what we get in our routine labs. 1 bacteria per high power field. Leukocyte esterase 3+ positive. Nitrites were present, and urine culture has grown E. coli, which is 10⁴ colony forming units. So my question to the experts, when we get such kind of urine report, how do we interpret? What is the importance of this bacteria present? Does it really mean this is urinary infection? Does leukocyte esterase positivity or nitrates present tell us, confirm that this is bacterial infection? If at all we don't have anything in the urine culture, if only urine routine report shows this, do we say, confirm that this is urinary tract infection? So what is your comment on from this report?
So from this report we can
there, 25 per half hour, definitely there is significant leukocyte UTI. Then bacteria is present, leukocyte esterase and nitrates all up. So a test alone, like for example only WBCs in urine, will not mean that the child has UTI. Similarly, leukocyte esterase alone, if it is positive, if the urine has WBCs, leukocyte esterase can be positive. And nitrites, when you see nitrates, they are more specific for the pathogenic bacteria in urine, which can convert nitrates to nitrate. So it's not sensitive, but it is specific. So a test alone will have low specificity or low sensitivity. But if we combine WBCs, bacteria, leukocyte esterase and nitrites, so the sensitivity they say increases to 98% and specificity to 70%. So it indicates that there may be 30-35% chance of having UTI, but always confirm it with culture.
Our usual experience from the routine labs, what we do, there are certain labs from the institutes where they are going to say yes or no. Either it's yes or no. So they will say 2 or 3%, or they will say 50-60%. But there are certain labs where we have seen they always give that notorious report of 7 to 8%. And then for us it is a dilemma. You say UTI is more than 5%. And that is the reason why we wanted to point out that these other markers, if at all we don't have a culture, or culture takes little time to come after 3 days. So meanwhile, if we have got leukocyte esterase positive, nitrites positive with cells more than 10-15, in that we should take into account that this is a urinary tract infection till the culture reports come. So we have seen that urinary nitrates, they are very specific but not very sensitive, and leukocyte esterase is very sensitive but not very specific. That is the reason why you should take both into account. Now these are the urine culture report given by the lab, which was done on disc diffusion testing, and this is showing E. coli. Now, what are the comments from this report? Do you think this report is reliable, or we should really think into some other parameters?
Definitely. So some strains of E. coli are even like common and they are not pathogenic. So the colony count has not been mentioned. Then minimum inhibitory concentration, MIC, and sensitivity, whether it is intermediate sensitive, commit sensitive, resistant, everything has been mentioned.
Right. So this is the report.
Definitely incomplete.
Yeah, incomplete report. So this is done by most of the labs, where there are those typical reports with plus, minus, and we are really confused. So this is not an ideal one. This is how a report of urine culture should be read. And what is your comment from this report?
So as you can see, the colony count is 10⁵ organism, which satisfies the definition for urinary tract infection. And you can see MIC and the sensitivity report here. So definitely we will see that we'll go for a antibiotic which is like the 3rd generation cephalosporin or amoxicillin, rather than again going for higher antibiotics. We can rely on this report.
Many a times we have started the antibiotics before that is the ideal way. Before you start antibiotics, culture should be sent. There are two things. If the antibiotics has been started from, let's say, other person and the patient is then referred, then the colony count becomes a bit dicey, because sometimes you'll get 10⁵, 10⁴. So you have to kind of see the clinical presentation. If it's fitting in, you will still label it as UTI, even though the culture is not as per the definition. Secondly, once we get the report, many a times we have not used the antibiotics which the sensitivity is showing, but the child has responded. So the point to make here is, even though the MIC report is important, many a times the in vitro and in vivo sensitivity differs. So if the child has clinically responded, just wait, and what we can do is repeat a urine routine, let's say after 5 days of antibiotics, and see whether the leukocytes have decreased in them. So sensitivity is just to guide that in case if the child has not responded to your line of treatment, then you should change the antibiotic. This is just a guide, and also to prove that the child actually has a urinary tract infection.
Another common practical point what we face in OPD basis, we get these culture reports. They all mention about IV antibiotics. Now we are more interested in knowing about cefixime. That is the most common molecule what we are using on OPD basis. And I have seen most of the institutes, they don't mention about cefixime sensitivity, they don't mention about sporadic cephalexin sensitivity. They just mention about amoxicillin, which is applicable for IV amoxicillin. So what is your experience that does any lab do this oral antibiotic sensitivity also?
So, sir, like in this case, the ceftriaxone, if it acts as a surrogate marker for that, the cefixime will be sensitive to it. It's like many antibiotics, they don't test all the antibiotics. Like for amoxicillin, ampicillin is a surrogate marker. Similarly, if you have a first generation cephalosporin, it is applicable to all first generation cephalosporin except cefazolin. And similarly for third generation cephalosporin.
So we can cross correlate.
Yes.
Should we do culture for all patients? If suppose
Yes. So for diagnosing, for labeling a child to have a UTI, urine culture is needed.
if suppose patient is not febrile, only lower UTI is there, like burning and all these things, and you get urine routine.
I think we'll go to, we have a case,
Okay.
so we can discuss that. This was a febrile UTI case.
Okay.
We'll also come to that
Okay,
because
okay.
that is also a common scenario we usually see in our OPD.
But if the sensitivity is there for the oral antibiotic, we should go ahead with the oral antibiotic.
Definitely, child on OPD basis scenario we are discussing that part. This is the IPD scenario. Child came, an infant who was little sick looking, high grade fever with chills without focus, was hospitalized, and that is the reason why we have said in-out catheter method. And we have done this. So 10 days to 4, 10 days to 5, that is significant colony count. We have got a bacteria and we have got a sensitivity pattern. So
The
this
duration?
child, and we have got MIC values also mentioned here. It is not plus minus something like that.
So duration?
This was fever for 3 days.
No,
High grade
antibiotic.
fever.
We'll come to that.
We are coming to that. So why this colony count is important is clean catch or midstream 10 days to 5 units. Catheter sample 5 into 10 days to 4 colony forming units is significant. And for suprapubic, any number of organisms is taken as significant. So that suprapubic sample is something what I think everybody has to now practice, if at all. If you are now having been diagnosed this case as a urinary tract infection, what are the most important points in the history and in the physical examination that one must evaluate?
So there are 2-3 scenarios. Now this child was an infant. So definitely we should go back, ask the mother about the antenatal USG. Sometimes we have second trimester ultrasound only, sometimes we have third trimester ultrasound. But we should make an effort to see what the report is, whether they have mentioned any antenatal hydronephrosis or hydronephrosis, because we will be more vigilant if we have a report like this. Secondly, in infants, we cannot ask the history about whether they have dysuria. So definitely we'll ask history about whether the stream of urine the mother feels is like weak stream or whether he dribbles. Then constipation is very important. This factor for causing UTI and for preventing the resolution of other things which cause UTI. And on examination, it is very important to examine the genitals and the spine of the child. So because we want to rule out any neurogenic cause or any, maybe the child underwent a surgery on the urological tract for some reason and now he's developed the symptoms. So spine, genital examination, then palpating the abdomen for bladder, palpating the kidneys whether they are erodible, fecolids, very important, older children sometimes find fecolids. So all this examination, clinical history wise and on examination is very important.
Well, sometimes Wilms tumor is missed. We are seeing Wilms tumor well palpated if you think of UTI. So that abdominal mass is also very important. So we are very confused here. We see so many phimosis and especially in infants. Now what is the age group where this has to be referred to a surgeon for surgery? And what is the physiological phimosis? What is the pathological phimosis? When should we really refer them for surgery in a case of UTI? If single episode of UTI and if I find phimosis in an infant, is it an indication for surgery?
So alone phimosis, if it is not associated with anything, only the mother, you notice that you are not able to retract the bones, and it is very common to have physiological phimosis 3 to 5 years old. So what is pathological is that phimosis with you can see sometimes a whitish ring or a scarring ring here near the prepuce. So that is definitely pathological. Or if the phimosis is associated with, let's say, some dysuria, some urinary complaints, so that time we can take cognizance of that. But otherwise, we should not make an attempt to like forcibly retract the prepuce, because then you may end up scarring, causing scar.
I just have one comment. So if the phimosis is, that's a common complaint that there is ballooning of prepuce.
So that is phimosis, but doesn't mean that it needs to be treated. If the mother says that there is poor stream, or if there is history of recurrent melanoprostatitis, that recurrent there is inflammation and redness over that area, then it is supposed to be treated. Or if it persists beyond 3 to 5 years, then it is supposed to be treated. Otherwise, this is the common scenario which we see. But when we ask the mother how is the stream, she will say the stream is very good, only there is some ballooning, so that does not need treatment.
Because this is one of the very common situations in our OPD practice, where mothers are very much anxious about this, and they want n number of things to be done. They want some oil to be put in that opening. Then some of them want to forcibly retract it during bathing. Then the other very common scenario regarding this was application of steroid creams. Most of the practitioners, they also recommend application of some steroid creams. So these are all not the rational ways of managing this. So you can definitely wait for 3-4 years also.
Yes.
No need to retract it, no need to put any oil, no cream, no massage, nothing. So that is one of the very take-home message for this phimosis.
Few of the surgeons, they recommend almost they can wait for 14, 15, 16.
Yes, somehow the pediatric surgeon they advise, but
Yeah.
I'm not sure how relevant it is. Like sometimes I think the thing which they follow is if the mother is complaining of posting just to see whether it's because of phimosis or the child can have underlying disorder, they recommend that desonite cream for local application, and if it improves, then they are sure we need not go ahead with any other intervention for this child. Probably that's the reason.
So another very common situation, just now I got one child, it was an 8 years old girl. Just now she came to me in my OPD that she has got dysuria. The moment she came, I had a question in my mind, I examined her pants. As soon as I saw there was the labial adhesions. And I told her mother, that mother told me, doctor, you have told me this 2-3 years back. Because of COVID I did not go to KM hospital. And now also I will go in Diwali. Then I had a very lucid discussion with her that this is not the way she is not taking it seriously. So this is another second common problem is labial adhesion. And I have seen mothers are extremely panicked the moment we tell and the moment we say now this has to be surgically corrected. So can you make a comment on this condition? It's very common. I see in my OPD almost 2 to 3 cases in a month, which I refer to Shrodriya sir. And he does it in just 2-3 minutes.
Yeah, so it's just an OPD, he just releases those signing cream. It's an OPD procedure, and then he just advises some lignocaine cream to avoid the discomfort. Otherwise, yeah, but it does lead to these symptoms like dysuria, and in fact many a times they come with incontinence, the dribbling of the urine. So that's why looking at external genital is very important, because this is something which gets missed many a times.
And it's just application of estrogen creams.
Yes.
Most of the mothers, they stop applying the cream once it is opened, and after a month again it is back to cycle. So that is why giving advice of application of estrogen cream for at least a month or 2 is very important, and good follow-up is important. Now this child received IV ceftriaxone. Child was afebrile for 36 hours.
So one question with phimosis, is there any possibility that it may lead to back pressure changes like what happens with PU valves?
No.
Not at all. If left untreated also, then also.
Yes.
Even if
Because
ballooning
it
is
can lead
forming.
to recurrent melanoprostatitis because of the collection of the smegma in the folds. It can lead to that, but per se it does not cause recurrent or back pressure changes.
So this child received IV ceftriaxone. This is our common IPD situation. After 3 days, fever is gone, and now mother and father is very keen on asking for discharge. So this is our daily situation. Now after this 3 days of ceftriaxone, fever is gone. Can we switch this child to oral antibiotics and discharge? Now this is our very important question to you. Or should we change the antibiotics as per the sensitivity pattern? And most of our reports don't have oral antibiotics, as you have just pointed out. So in such cases of febrile UTI, how long we should give IV antibiotics? Which one we should continue? When should we really change it to oral? And which one is the choice?
Now, as we started IV ceftriaxone and the child was apparently febrile after 36 hours, if the child is accepting well orally, not dehydrated, and fever has come down, touch the baseline, so we can change the antibiotics to oral antibiotics. The exception being neonates and children less than 3 months. Secondly, should the antibiotics be changed? Now we empirically start antibiotics and we wait with the culture. So as madam said that in vitro and in vivo susceptibility is different because we check the MIC, it tells you the lowest inhibitory concentration when we compare the serum or the blood. But sometimes what happens is antibiotics like beta-lactams, they achieve a high concentration in urine. So even if the report does not show or it shows maybe resistance, we can still continue with beta-lactam of the oral corticosteroids. How long the baby should receive IV antibiotics? Infants and especially neonates definitely culture positive 10 to 14 days you should give. Older children 7 to 10 days, and if you have lower urinary tract symptoms just or adolescents then 3 days also suffice.
Should the urine culture be repeated after the fever is gone?
If
I
the
would
child
like to ask this question to the audience. Do they normally repeat urine culture after
Ideally,
receiving
we
the
should.
culture? So,
It depends on response. If patient is improving, we can.
yeah, so if patient is improving and something what we do that after starting antibiotics will day 4 maybe repeat urine routine and microscopy. If it shows normal and patient is symptomatically better, then there is no need to repeat urine culture. If the patient continues to have fever beyond 72 hours, then that might mean that the pathogen is actually resistant to the antibiotic you have started. So I would go with the culture report and change the antibiotic and do an ultrasound and see whether there is some collection or some pus which needs to be treated. So in this scenario maybe I'll change antibiotic, but otherwise there is no need to change antibiotic or to repeat a urine culture. In neonates, however, they being a very susceptible population, maybe after completing the course of your antibiotics, you can repeat a urine culture. But otherwise, not.
Should we repeat urine routine till it becomes sterile or normal?
So when you start an antibiotic, definitely we want to see the response. So clinically we do see, but also we have to sometimes see what it is happening to the urine. So in that case, we do urine routine, and after that, once we have documented that the patient has responded, we generally don't recommend repeat the urine routine at the end of antibiotic.
So routine is also not required.
So once, definitely to document.
Now once it becomes normal, it's okay. But
It's okay, huh?
but if it is having first sales, suppose.
So definitely then you'll have to
So till it
repeat.
becomes
Even
normal,
if
you
you
should-
change antibiotics, you'll have to repeat after changing the antibiotics.
So
To
till
see
it
what
becomes
is
normal.
The other very common scenario on OPD practice was when we send this urine culture and all of it after 3 days we get a surprise that culture from a particular lab shows reports like Burkholderia cepacia, then they show all this gram-negative organism, protease and all those things. So how reliable are these? How do we know that a community acquired infection, if it is a non-E. coli, suppose if it comes on the report, and how do we trust that reliability? Whether this is some, what do we say, collection method problem, or it's really a true report?
So most common organism we know is E. coli, but not necessarily. Sometimes there are atypical organisms also like Klebsiella and Pseudomonas. Especially if the child has been hospitalized for a long time, we may accept a nosocomial infection. However, when you grow organisms like Enterococcus, which is like it's a commensal, so you may need to repeat the culture if you are doing an organism like Enterococcus, or if you have mixed organisms, like you are doing both E. coli along with other some organisms. In that case, then we will doubt the reliability first of the urine collection method, and then we can think about whether the lab has.
So on OPD basis, a healthy child, if at all it is a non-E. coli, one should think twice before you
If the
interpret.
child has no symptoms, then the urine routine is normal. Then again we will have to think over about the culture report and how it was collected, what the lab.
Again, I have a comment. So if it's a non-E. coli, it is said that you should, and if the child is symptomatic, you should suspect an underlying abnormality. Because in face of, let's say, vesicular reflux or a posterior valve, more commonly they will get a non-E. coli infection than an E. coli infection.
So non-E. coli report has to be always taken seriously, interpreted it properly, and examination has to be again and again done. So that is very important when we see a non-E. coli report coming. So empiric antibiotic of choice, all of us know ceftriaxone, cefotaxime, amikacin and coamoxiclav. This is parenteral antibiotics. And oral, all of us know cefixime, coamoxiclav, cephalexin and ciprofloxacin. Although ciprofloxacin we usually avoid in children less than 8 years. Now this is the another most important question. Once we have diagnosed the case of UTI, previously in my undergraduate and graduation days, it was a dictum. Any child who comes with UTI less than 5 years, you have to do MCU, you have to do DMSA, you have to do sonography. It was a compulsion that you have to do everything. Now we are seeing that scenario is changing. So what is the latest guidelines about the...
So first thing, recent guidelines of Indian Society of Pediatric Nephrology will be soon published, but this is just a snapshot from that. So any child with recurrent UTI should be evaluated thoroughly. If he has, so recurrent UTI is defined as more than one episode. So if the child has had proven febrile UTI with a culture, so that is UTI means culture, not just pus cells and previously labeled as UTI. Because I am sure you must also be facing the parents coming, हमारे बच्चे को UTI है. And again we have to ask them what were the symptoms, then they say no, the urine routine was done and it showed pus cells. So we have to be really sure rather than analyzing them as a labeled known case of UTI to see actually whether it was a UTI. So if there is a recurrent episodes of UTI, then you have to evaluate the child thoroughly, that is with sonography, DMSA scan and MCU. And if the child has had only one UTI, first thing is you have to rule out features of bladder wall dysfunction, which will come in another case. And then if the ultrasonography is abnormal, then you have to go through MCU and DMSA. And if it is normal, but it is labeled as atypical UTI, if let's say the child's creatinine is high, or if the mother is giving history of poor void or difficulty in voiding or any other voiding symptoms, then and if the age is less than 3 years, then they should go ahead with MCU and DMSA scan.
So not every first episode we posted for MCU, because we are worried about MCU or why first episode. So this is the clear-cut guidelines now. If it is the second episode, we should go for MCU. If MCU is abnormal, one should go for DMSA later on, after the infection is settled. And this atypical UTI, what Madam has just pointed out, non-E. coli infections, those who are non-responders with high creatinine, septicemia, these are the atypical UTIs which one has to really take it seriously.
And
Now,
when,
suppose if
so ultrasonography when should be done?
So it
Immediately, or you
It
can
can be done immediately. There is no this thing that you have to wait till the UTI is resolved. Because many a times, in fact, you will find features of pyelonephritis in itself. So that kind of add to your diagnosis of. I mean, you need not wait for culture. If there has been recurrent UTI, the child is febrile, you do a sonography. There is no time limit for waiting for doing a sonography. But for MCU, of course, the UTI should be treated before you do an MCU. UTI should be treated, and they recommend 2 weeks after the treatment.
we usually document urine routine after
Yes.
we started the treatment. When urine routine shows good infection control, then we go for an MCU. So MCU should not be done immediately in that process of UTI. So first treat the condition and then investigate. But it has to be done. It has to be investigated. So coming further, this child now, suppose this fever did not respond in 72 hours in this case, in this scenario. What should be the possibilities? Should we change the antibiotics as per the sensitivity pattern, or should we get an ultrasound done?
So definitely, if you have a culture report and fever is not responding, even there is persistent leukocyturia, so we will rely on the culture report and change it. At the same time, we will do ultrasonography so that we don't miss whether there is an obstruction. If it is present, then that will definitely impede in your treatment. So maybe you will have to drain the urine, like catheterize the patient, and look for any collection like this pyelonephrosis, so that unless you drain it, the fever will not respond. So ultrasonography, there it becomes must.
So usually this resistant
And we
UTI.
check compliance also.
So resistant UTI we usually see in the complicated UTI part with underlying problems. For routine urinary tract infection, the response we usually see in 72 hours.
Yes.
And if at all there is no, if at all child is very high, severely febrile, 103, 104, toxic, one should not miss perinephric access and all this. So that is very important. So coming to the second case, now this is a 10-year-old girl. She has been referred with history of 3 episodes of febrile UTI in past 2 years. And each episode she had this lower urinary tract symptoms like increased frequency, burning, urgency and occasional daytime wetting. This is most important. She had this void history of only 3 times in a day. she used to void urine only 3 times in a day. This is one of the very significant history mother has given. And she has those typical holding maneuvers where she used to cross leg posture, she used to stand, and there was history of constipation. So, expert, please guide what is this case and what are the possibilities in this situation?
So this is a typical case of what we call as bladder bowel dysfunction. So a typical adolescent girl will come with history of recurrent episodes of febrile UTI. So even though we have given this, the parents usually don't come up with this history unless and until you prod into it. And history of constipation is very difficult to get because when we ask, does the child pass his stools daily, they will say yes, they pass. But it is and when we ask them repeated questions, they'll come up with yes, in a day my child passed 2 to 3 times. When we ask why, so they say every time my child will pass small amount of stool. And in fact, we'll come to that stool chart. We use that guide called as Bristol stool chart to show to the because in a 10-year-old girl, of course, the parents doesn't know what kind of stool the child is what kind of stool the child is passing. So when we show them that chart, the child will eventually come up and say, and then you realize that actually the child has constipation. So that is very important. And history of holding maneuvers, unless and until you ask the parents that whether she tries to hold the urine, whether she attends a difficult kind of posture like crossing her legs or kind of jumping at one point, trying to withhold and postponing the voiding. So that is the typical features of bladder bowel dysfunction which needs to be asked.
So, when should we suspect this bladder bowel dysfunction in a child? So, these are all the features what madam told. If somebody has presented with constipation, somebody who has got these maneuvers to postpone voiding, and this is very important, voiding less than 3 or more than 8 times in a day. Somebody who has got forced urinary stream, thickened bladder on sonography, and when post-residual volume is more than 20 ml, or if MCU shows abnormal bladder configuration, this is typically this spinning top deformity. What is this spinning top deformity? What is the significance?
So, spinning top deformity is usually seen in a condition which we call as detrusor sphincter dyssynergia. So, normally when the detrusor is contracting, the sphincter should relax. So, that is the normal phenomenon which occurs during voiding. But in this patient, what happens is while the detrusor is also contracting, the internal sphincter also contracts. So, that gives a typical picture which is called as spin top deformity, which is seen in this urethra, which is not normal for a child, for a girl. Usually seen in girls.
It's non-neurogenic, neurogenic bladder. So this is the figure. Can you just make a comment about
this? This I thought was very important because even though sometimes people say constipation is overrated but we have seen that resolution of constipation, the UTI does, the recurrent episodes of UTI does get resolved. So here we have just shown that the rectum, the stool in the rectum, it kind of presses on the bladder, and that leads to continuous irritation of the bladder. Many times it also presses on the urethra, and that leads to retention of the urine, thereby leading to predisposing those children to urinary tract infection. So unless and until this constipation is taken care of, many times they will just keep on having the recurrent episodes of UTI.
Now this child, this 10-year-old girl, her ultrasound shows kidneys were quite normal. She had mild bilateral hydronephrosis, thickened bladder was there, and her MCU showed spinning top deformity with dilated urethra, and there was a post-void urinary retention plus trabeculated bladder. So these are all very classic in her background of that history of constipation. So this was a broader term, bladder bowel dysfunction, and I think this is one of the treatable entity. So if you treat the constipation part, definitely the UTI is going to get treated. Coming to this third symptom, where just now Mahesh and Dr. Dalte was asking that this was another 10-year-old girl who was investigated, and because of the complaint of periurethral itching. So this is one of the very common complaints in pediatric age group, that mothers always say that my child is having this periurethral itching or genital itching all the time. Otherwise child doesn't have any fever, child doesn't have any dysuria per se, and urine routine report is done, which shows typically urine culture shows E. coli and typical more than 1 lakh colonies. She has got no fever, no urinary symptoms, there was no past history or any other significant history in the past. Now how should we interpret this kind of situations?
So definitely the urine is showing bacteria and it is growing bacteria.
Yes.
But no clinical features suggested, and it's an older girl, 10-year-old girl. Then no history of repeated UTI in the past or fever without foci, and ultrasound may be completely normal. So this is what we call as asymptomatic bacteriuria. And as we said that in the genital tract or in the urogenital tract, some strains are there even of E. coli which are like helpful strains or non-pathogenic. They are just colonization. So if we try really hard to eradicate these strains by giving antibiotics injudiciously, so what we will do is we will replace them with a more pathogenic variant. And then it will be, maybe the child was not predisposed and now because of our use of antibiotics now harboring these organisms having UTI. So this injudicious use of antibiotic just in the presence of asymptomatic bacteriuria is not.
Now these are the 10-year-old girls, but we see
girl with no features.
We see such kind of situations very often in less than 2 years, less than 5 years children, especially girl child, and mothers are very much anxious about that periurethral itching. They are very much that all the time my child puts hand there and itching, and they do a test, and some non-specific lab does non-specific reports of cultures composite. So if we don't have those classic clinical features of fever, dysuria, or suppose child doesn't have any other classic symptoms, I think it's better to repeat a urine routine or urine culture from some standard labs, especially institutes, and then take the decision of antibiotics. So this is another thing which very commonly.
Another important thing is sometimes periurethral itching might have different causes rather
yes,
than UTI.
exactly.
It may just be a irritation. It may be because of constipation. Also, we have seen that
Fungal infection.
Yes, fungal infection, not able to pass through properly, or sometimes when you have some term called hypercalciuria, sometimes that also can cause irritation and burning. We have to consider all these.
So this is asymptomatic, not significant. Ensure the method of collection, no treatment required. Now this is a 4-year.
In that, why should do actually urine routine and culture?
Like so
We should not do.
That
I don't know what is done, so that's why. Because that's a common
This is
scenario.
the common scenario which we are discussing.
Yeah.
That most of the time mothers are anxious, and then a pediatrician usually says, "Chalo, let us do a urine routine."
So we should not do.
We should not do.
Yeah.
So unless we have got a classic situation of a UTI, we should not do this test. And the interpretation of this test in this background, sometimes you may have to repeat it if needed, but you should not treat when the symptoms are not.
But if symptoms are not there, why to repeat?
Many a time, just for periurethral itching, you can just advise sitz bath.
That's what,
Using
yes.
the KMN
Ideally,
powder,
yes.
in a warm water, many a time that itching subsides.
And
Actually, urine routine is not
Yeah.
indicated.
And it says, but should we use Dettol or something? Or just plain
No,
water?
only KMNO4 powder,
That's
potassium permanganate powder, just pinch and warm water and ask in a tub, ask them to sit for 10 minutes in the morning, 10 minutes in
And
the
that
evening.
works very well actually.
That actually works very well.
Fantastic. So can we use Savlon instead of KMN4?
And I think that is more irritating.
Irritating.
Yeah, it does not have a soothing effect.
Even sometimes plain water also works.
Yeah, in fact, just warm water, asking them to sit in a warm water also does the trick.
And even for small child also,
Yes.
any age.
So this is another case. 4-year-old boy presented with periorbital puffiness and had cola-colored urine. He was hypertensive, had mild pediledema. Urine routine microscopy showed 1+ proteins. Then there was 60 to 70 RBCs, and at the background there was 10 to 12 WBCs. He had low C3. So this was a very classic case of our acute glomerular nephritis. Now in this situation, we have got WBCs of 10 to 12. So do you say that this is AGN with urinary tract infection? And
So
does
I
this
would
mean-
like to ask the audience.
It's a diabetes along with the RBCs.
Yeah, so many a times we see that the child is labeled as UTI along with AGN. So it is very difficult for a child to have two diagnoses at one time. So this is actually a classical case of AGN in which many a times, in fact, I would say 90 to 95% of times you will see WBCs. So that's why urine culture is very important to label a child as having a UTI. And just having WBCs in urine does not mean that the child has UTI. In fact, this is a case of AGN, but many a times in a nephrotic syndrome also, when you are doing a urine routine to look for proteinuria, you see some 7 to 8 or 8 to 10 WBCs, and then the child is labeled as nephrotic syndrome with UTI. Of course, the child of nephrotic can have a UTI, but if he does not have any symptoms of, let's say, fever or any other voiding complaints, you should not label it as UTI. And if you really want to prove that it's a UTI, do a culture.
So these are the causes of WBCs in the urine without a urinary tract infection. It can happen in fever, it can happen in nephrourolithiasis, acute glomerular nephritis, and sometimes when there is stent in the ureter. So one should know the causes of increased WBCs in urine without a infection. So take home message. Would you like to please?
So I think we have covered almost all of this. So the first case was the point to bring out that infants have very non-specific symptoms. So even they can sometimes present just with failure to thrive. And many times when you are evaluating for failure to thrive to look for some low-lying infection, you find that the child actually had a UTI, low-lying, which was going on, even though there was no fever. So the symptoms in UTI are very non-specific. And as again and again reiterating the fact that diagnose a UTI only by doing a urine culture, and colony counts become important from the method of collection, and always in a child with UTI assess for the presence of bladder bowel dysfunction.
So now we go to the very common, most important cases of this enuresis now, nocturnal enuresis. This is a 6-year-old girl. She was brought by mother, and she was saying that this child is constantly wetting her bed every night. She was very irritated. Now this is a common situation, what we say. I would like to know regarding this enuresis part, what are the different aspects of enuresis? Why do we say nocturnal enuresis? Why not this daytime enuresis or enuresis per se as a terminology? Why we say nocturnal enuresis?
So actually, incontinence that we say, it is involuntary leakage only, and it can be either continuous or intermittent. So enuresis means that this intermittent incontinence is there, and these episodes of bedwetting, they happen during sleep. So the word is enuresis. We add nocturnal enuresis just to specify that it happens during sleep. Otherwise, you can just call it enuresis.
Does it make a difference? Daytime enuresis and nighttime enuresis?
So it's daytime incontinence, and if it happens like during sleep, this intermittent episode, then it is called specifically enuresis.
Okay.
So actually now the labeling is only enuresis, because if the child sleeps during day and passes urine, still it is
Still it
enuresis.
is. So during sleep is very
So what is this initial history required when we want to establish a diagnosis of enuresis? So suppose it is a continuous
What is it?
incontinence.
If it is
Involuntary.
continuous dribbling or continuous incontinence, that means there is some structural abnormality, like you may have ectopic ureters, which are continuously draining, or some fistula, like a vesicovaginal fistula, which is continuously draining. So, or a neurogenic bladder. Child is like continuously wet, dribbling.
And if it is intermittent,
So, intermittent and discrete can happen, as we said, in overactive bladders. It can happen when it is in daytime incontinence, and at night or during sleep it happens and it is enuresis. And it is very important, the ICCS has said that these lower urinary tract terminologies are to be applied for children 5 or more than 5 years.
what is the standard definition of this enuresis now?
So if, as I said, intermittent incontinence while sleeping in a child more than 5 years or 5 years of age, and it should happen at least once a month in the past.
Some diurnal enuresis terminology was there na before.
Diurnal enuresis.
Ah.
So enuresis is
It's just the enuresis.
It's just enuresis.
Age group is same for the boys and girls.
Yes.
The 5
Yeah,
years now.
same age. 5 or more.
During sleep month.
So this is more than one episode for 3 consecutive months. This is something which is very important, and child should be more than 5 years. What is this monosymptomatic and non-monosymptomatic? This is something what we are interested to know.
So, we have to label a child as having non-monosymptomatic if they have associated daytime symptoms. So not when they sleep, but when they are awake. So if they have daytime incontinence, they are wetting their undergarments, or if they have other voiding symptoms like poor stream hesitancy, or the frequency is more or less, so that is less than 4 or more than 7. So we call it as non-monosymptomatic because it has different connotation. For a enuresis, we mainly involve behavioral therapy and alarms. While for non-monosymptomatic, urotherapy becomes a very important aspect. which is actually important for enuresis also, but urotherapy seems to be working when they have daytime symptoms. So we'll come to the urotherapy things where we advise them good voiding habits. That is, they should void every 3 hourly at least. So before going to school, at least once in school, coming after school, before going to bed. So that's the normal pattern that the parents should advise their children to do. And drinking adequate amount of fluids during the day and avoiding constipation. So this is the urotherapy thing which usually works in non-monosymptomatic. And for monosymptomatic, where there is no daytime symptoms but the child usually only wets when he sleeps, then it has different pathophysiology and we have to kind of dig deeper into that.
What is this secondary enuresis? We say it's very common, secondary enuresis.
So secondary enuresis is very important because there are two things. One is it can have pathological underlying features. If it's a secondary enuresis, that means the child, in fact, patient of juvenile nephronophthisis, they can present with enuresis. So if the child has been dry for at least 6 months and then present with enuresis, you should be really on alert because it can have two reasons. One could be some recent psychological impact which the child might have had because of, let's say, recent loss in the family or recent change of their surroundings, so that leads to secondary enuresis. Or, very important, to rule out other illnesses like diabetes insipidus or diabetes mellitus because they have polyuria and then they present as enuresis.
So now this girl, 6-year-old, what we talked about, she wets the bed only during the sleep. She has got no daytime incontinence. What are the red flag signs that we should look in such children who come with enuresis, complaints of enuresis?
So, if a child has developed secondary enuresis, then we will be even more alert to look for, sometimes enuresis can just be a sign of underlying CKD. If the child also has poor growth, hypertension or something like that. Again, then kidney has tubules and there are many tubular disorders like renal tubular acidosis, Barter's, DI, which have polyuria. And obviously because of polyuria, the bladder will not be able to hold all the urine, so there might be enuresis. So we have to rule out these conditions also. And again, one more important thing is the voiding disorders in children. But these voiding disorders will also be associated many times with daytime symptoms. So all these red flag signs should be looked for, and one more important thing is constipation. Sometimes in secondary enuresis, when the child was dry before and now has developed these symptoms, the increased urgency, frequency, it all can be just related to constipation.
So this history of weight loss, polydipsia, polyuria, stream, then constipation, so all are very important when one should ask in a negative history when your child comes with constipation. And what about this comorbidities? So why does enuresis occur? This is the first. What is the pathophysiology of this, and what is the significance of these comorbidities if at all we see in these children?
So many times we have this myth that if a child has enuresis, then he must be having some psychological disturbance or some family problem, and that's why he's wetting the bed. But this is a very big myth which we need to bust. So enuresis involves three main things: that maybe you are producing more urine, you have more nocturnal urine production, and your bladder capacity is small, and maybe your sleep threshold, the arousal is like the threshold for arousal is very high rather than maybe you're a deep sleeper. So all these factors together can, or single factor or in combination, can cause enuresis. And comorbid conditions, sometimes the child will have features of obstructive sleep apnea, ADHD or constipation. So these are coexisting factors. The importance of these factors is that they may, your anti-enuretic therapy might not work unless you address these factors also. So maybe you are trying everything to manage the child, but because of the presence of these factors, it becomes refractory. So it's necessary to manage these factors. Comorbid conditions.
I did not consider hypertrophy children who present with this. Do they have more propensity for nocturnal enuresis?
Yeah, so what happens when you have hypertrophy? Sometimes the disturbed breathing pattern, the negative intrathoracic pressure, etc. It may cause release of natriuretic peptide (ANP), and that will increase your urine production. You may have enuresis. So sometimes when you tackle these factors, you see that has helped in managing enuresis.
So now, whenever you want to evaluate a child with enuresis, first and most important is history. That child has been never dry when asleep for more than 6 months. This is primary enuresis. Any child now who gives us a history of polydipsia, polyuria, nausea or weight loss, we should rule out chronic kidney diseases, diabetes mellitus and tubular disorders. Now, when we rule out these daytime symptoms, ask a 6-year-old, she had this nighttime bedwetting, she had no daytime incontinence, she used to strain while passing stools most of the time, probably she had constipation and she had a normal physical examination. Now, this is the commonest question what all of us want to know. How should be our approach? Now we have got so many therapies, we have got so many medicines and we are really confused where to apply what logic, where to apply this alarm therapy, where to go for desmopressin, where to go for imipramine, where to go for so many newer gadgets which have come. Now, is there any peculiar approach to this kind of scenarios, and what are the basics, what is to be needed when we want to go through such cases? So, if I see this girl in my OPD, what should be my next action before I take a step of management part?
So, I'm sure everyone must be having this case in their OPD. First and very most is this cases take a lot of time because you have to kind of first talk to the parents as well as to the child. Because what the child is feeling many a times they don't express and it kind of acts as a vicious cycle. Many a times still we find parents who scold their children, who beat their children, who get angry, and it's a natural human response. So first thing we need to explain to the parents is that too much of patience is needed from their side. And also involve child in this conversation, because once you involve the child seems to become responsible and kind of take all the action which we are advising. So what we call as urotherapy and demystification. So telling the parents that this is not child's fault, because most likely the parents feel that my child is lazy, he or she does not want to wake up in the night, that's why he is wetting the bed. So it becomes very important to stress on the point that it is not out of laziness, but there are these pathophysiology which can be present in your child which might be leading to the enuresis. After explaining that and explaining the good voiding practices, we advise them to keep a voiding diary. So keeping a voiding diary is very essential for many reasons. We come to know about their compliance with the therapy, whether they will be able to be compliant for further therapy which we are going to advise after having a look at the voiding diary. Then voiding diary also gives us an idea about what the intake is like, what the urine, the frequency is like, and what the total urine output is. So many a times we have picked up polyuria when the children they keep the voiding diary. In fact, it is very strange, though none of the book mentions this. Once we ask the children to keep this voiding diary, somehow their enuresis kind of decreases. I don't know the phenomenon behind it, but kind of they become responsible and they note it down and they'll come happily saying that, see, I have wetted my bed. And because we also combine it with positive reinforcement, like we give them the star chart and we give them the stickers of stars and we tell the child that when you wake up in the morning and if you have not wetted the bed, you put this star. So that kind of reinforces them to carry out all the good healthy voiding practices which we call during the daytime. So this is the drink and voiding diary which we practice. We give them a plastic measuring jar to measure the urine and the liquid in the during the daytime. And very important, at least 4 days voiding diary is very essential. So you can ask whenever the child is at home, like on Sundays, they are supposed to maintain this diary.
Now this is one of the very important slide. I think one should we'll go little slowly on this, because my question is, when should I use desmopressin? When should I use oxybutyrate? When I have to use both of them in combination, and when I have to use only alarm cycle? So that is the reason why this slide is one of the very important slides. So can you please guide us on this expected bladder capacity, maximum volume voided? Then we want to know this is a when we say this is polyuria, when we say this is a large volume bladder, or when we say small capacity bladder, and how it is going to help us in the management part by choosing these drugs. So please comment on this important part.
So if we like have an example, it will be very easy to. So bladder capacity is the formula very simple. Age plus 1 into 30.
Into 30.
So we get a value. Of that value, we see what is the 65% and what is the 150%. If the volume, when you see the voiding diary, so when you see the volumes, if they are less than 65% of that value which we have calculated, then that means it is a small capacity. And if it is more than 150%, definitely it's a large capacity. And if what is nocturnal polyuria, I will just tell that after getting up, the first void, if the child has been dry the whole night and gets up and voids for the first time, so that amount of urine, if it is more than 130% of that bladder capacity, that means he is having nocturnal polyuria. So he is producing more urine at night. So that will guide us to therapy whether desmopressin in these cases it is really helpful if you have nocturnal polyuria. So if we can example wise, if we can
Yeah.
it would be easy.
Now this was a case. Here, this is a 6-year-old child now, and his expected bladder capacity was 6 plus 1, 7 into 30, that is 210 ml, and less than 65% is 136 ml, more than 130% is 273 ml, and this is a voiding diary. Here we can see the maximum voided amount is 200 ml, which comes in between 136 to 273. So this is a normal capacity bladder. So this is normal bladder capacity. There is no polyuria. We can see that voided amount ATM is just 180 ml. So this is less than 130.
Not more than 130.
And the frequency also, we can see the frequency. It is just 6 times. So we have said initially between 4 to 7 is normal. More than 7 it goes into polyuria, and less than 3 is something what we say abnormal.
Infrequent voiders and frequent voiders. One more thing is that maximum voided volume, it should not include the first morning void, because that has accumulated in the bladder gradually overnight. So debarring that first void, the next void when you see, which is the maximum one, that corresponds to your maximum void.
So now can you comment on these three, 7 p.m., 9 p.m., 10 p.m. in this case? The child is taking this lot of fluids. So this is something which is the treatable. The first part of the treatment is this.
So that is the importance of voiding diary. Not only it gives you an idea about how much he is voiding or he or she is voiding, but also the child's intake. Whether it is too less, whether it is more in the evening, less during the day, all examples.
So how do we manage this enuresis, and what is the most important part about this? Why should we really manage this?
So it is very important to, as Madam said, we have to sit with the parents and counsel them that though it is not a psychological disorder in the child that is causing the enuresis, but if left untreated, then their child may have further psychosocial issues, like may have low self-esteem, may have cognitive dysfunction. He may be a subject to even physical abuse, teasing at school. Then the child will be very reluctant to go for picnics or any night stays because of this problem. That may affect the personality of the child. So it is important to counsel the parents regarding this. And if you do not treat enuresis, it will persist in the adulthood. 0.5 to 1% persists in the adulthood. So after counseling, then we will talk about urotherapy. So what is urotherapy? The child first should be told, the parents should be told that how and why this enuresis occurs. After that, the child should be made responsible for his bladder function, and he should be actively involved in managing his disease. So if you are like wetting your bed sheets, then change the bed sheets. Then as the star chart it will be positive reinforcement. The child will see that he is doing well. That will keep on reinforcing in his subconscious mind. So that reward system or the positive reinforcement is very important. And sometimes the child may be wetting the bed, even on the star chart, but the stars are not given for wetting the bed. They are for the good practices that the child is actively doing. So even that will help. Then sometimes parents have this habit of putting alarm and waking up the child, but that will not help in long term. Maybe for that day the child was dry, but that same practice will not help.
Actually, that is the confusion.
That is the confusion.
Most of them, they feel that alarm therapy is setting
Means
an alarm,
setting an alarm and
waking the child, taking him to the urine, and that is what is alarm therapy. Actually, what is alarm therapy and how does it work? And they say that this is one of the best strategies, even as compared to the drugs. So we want to know about this alarm therapy. Where are these alarms available? What is the cost of this alarm therapy and how does it work?
So, alarm therapy is basically based on conditioning of the child to wake up in the night when he wets the bed. So, there is a sensor which is kept placed in the undergarments, and then the wire is attached to a small pocket kind of thing which can be attached kept in the pocket or on the shoulder. It can be just fixed. So, it does not prevent leaking. It is that when the child just starts to pass urine, the alarm rings. And initial few weeks it's very difficult because everyone in the home wakes up except the child. So this is the common scenario which happens, and the compliance actually decreases. So you have to explain to the parents that this is going to happen, but ultimately this is the process of conditioning. So the child's brain gets conditioned that once I start leaking, the brain gets a message that the alarm will ring. So unless and until you have used it for 2 to 3 months, you cannot say that the alarm is not working because conditioning actually takes time. So, but it has been shown in studies to be the most effective way to treat the enuresis on a long-term basis. And it's available, the cost is 2,000 to 3,000. In fact, it's available on Amazon also. So this wet stop you can get, and in some medical stores also. So there are these 2 brands which are available, Free and Wet Stop, which are easily available.
Most of the guidelines say that you first use alarm therapy.
Yes.
Use it properly,
Yes.
proper technique. And if it fails, then the other modality
Yes.
like desmopressin and also.
Yes.
Because most of the general practitioners have got habit of writing desmopressin right there itself.
Yes.
So this is one of the very important things that one should know about alarm therapy.
What about fluid restriction in the evening?
Yeah, so that is important. So in that case, the child didn't have anything else. The bladder capacity was normal, the frequency was normal, but restricting the fluid in the evening, we have seen children responding to it. But then the most common thing becomes our child goes to play, then he comes or she comes and then they want to drink. So what do we do? In that scenario, it's very important to tell them to give the child lots of water during the daytime. So that kinds of keep them hydrated and make them drink less in the evening. So advising them that give them lots of water during the daytime but restrict it during the evening time.
Plus sweets or sugar products, any role for?
No. I mean, it has not been shown for pro or against, but of course caffeinated products and those sodas, drinks, they should be avoided during the night time.
Good avoiding practices.
And
I
plus
think
what
we have
investigations basic should we do?
none.
Urine routine or
So,
Sugar.
one thing, if you are suspecting those red flag signs are there, weight loss or growth retardation, or if the child has polyuria, if you are seeing on the voiding diary that there is polyuria overall during the day as well as during the night, if the urine output comes to be more than 4 ml per kg per hour, then you have to investigate.
In
Because
general-
very rarely they will have polyuria during the day. So in that case, you will do electrolytes, blood gas, sugars, and urine electrolytes and urine specific gravity. That gives you a basic panel of ruling out diabetes mellitus, diabetes insipidus, and other tubular disorders.
This is the last case, 10-year-old girl. She was brought with enuresis. Her expected bladder capacity was 330 ml and more than 130% was 430 ml, and this was her first void, which was 500 ml. So what would be the best management option here, since now we think this is going into that polyuric form? So do we prescribe desmopressin? What precautions we take while prescribing desmopressin, and how is this desmopressin tablet or tablet form, nasal spray form? So comment on this desmopressin now.
So when you document nocturnal polyuria and the bladder capacity is normal, so we'll go for desmopressin. Only thing, we have to give desmopressin with a lot of instructions to the parents and under supervision, because if the child has a habitual drinker of fluids, etc., and you're taking the desmopressin, then there is a risk of hyponatremia. So it is said that you should restrict the evening fluids to not more than 200 ml if ever the child wants to drink, and you should give it 1 hour before the bedtime. So this should be taken care, and if alarm therapy fails, then you can either combine the alarm therapy with desmopressin or shift the child on desmopressin. So a lot of counseling with the parents and their choice also matters while deciding the therapy. And if for short visits, like if a mother asks that my child wants to go for a picnic and all, so that time it is very effective to prescribe desmopressin.
The nasal spray tablet forms.
So with the tablet form you can be sure of the sustained absorption, and variability is not there. The nasal form has a lot of variability in the action, so the pharmacokinetics will differ. So we prefer the tablet form. It is available as melt tablet, 60, 120 and 240.
And how long should we continue this?
So you can use desmopressin for a long time, like 6 to 24 months. But whenever you use desmopressin, after 3 months, you should give a gap of like 7 days to see what is happening actually to the enuresis. So to re-evaluate, we should keep on giving this gap.
So during this.
And before we decide on starting any alarm therapy, we should always address the comorbidities.
So this is the final crux of our today's talk on enuresis. So can you please summarize this slide? What should be our approach and how it is going to differ, our management strategies as per?
So the biggest tool that we have in our hands is the voiding
Voiding
diary.
diary.
It gives you a lot of information. So minimum days, 4 days at least you should keep. Better to keep it on weekends because Saturday, Sunday the child will be at home. Then comorbidities, ADHD treatment and obstructive sleep apnea, all these treatments should be addressed. Then on the voiding diary, if you find a normal bladder capacity and no polyuria, then you will use either alarm or desmopressin. So both have 1A evidence, and definitely how motivated the family is in using alarm, that is a very important factor. So that is why you should discuss both the options with the parents. If you have normal bladder capacity and polyuria, definitely then you should use desmopressin, again under strict supervision. And if you have small bladder capacity and no polyuria, so small bladder capacity will mean either there is some detrusor overactivity which needs to be suppressed. So in that case, you may have to combine anticholinergic drugs like oxybutynin with alarm. And if you have multiple factors like small bladder capacity also and polyuria also, then you will have to use alarm plus desmopressin and anticholinergics.
So this is a clear-cut guidelines now. So that is why voiding diary is something which is very important, and all of us must practice that. And from that we should know the expected bladder capacity, less than 65%, more than 130%, polyuria, present, absent, small capacity bladder, over capacity bladder, and then we take those decisions of using desmopressin or using anticholinergics. And most common is we should have that practice of using alarm therapy, and that peculiar alarms, use it properly for 2 to 3 months, and if at all it fails, then you should go for desmopressin. So this is the take-home message from today's presentation. Thank you very much.
So mostly you have normal bladder capacity and no polyuria.
So what is the option? Alarm is the first option or desmopressin?
So because desmopressin has its own supervision and challenges, and also we will definitely go for alarm therapy. But again, it is not our choice only. How motivated the parents are. Sometimes when they start using alarm, they will be, child will not wake up, the family will wake up and he continues to have headache. So that may demotivate them. So you'll have to really sit and counsel that this may take some time. You cannot outright reject alarm therapy, at least use it for 2 to 3 months. But desmopressin, if the parents ask, we want to go for a trip and all, so maybe the alarm therapy will not work for that moment. So you can use desmopressin in that.
There is one question from the audience from live YouTube channel. This is Dr. Chaitali Raut. What she says, she had a patient, 3 years old female, who has presented with 4 episodes of UTI in last 1 year, and now now that patient is showing some hole near the vagina with live worms in it. Can you guide on this?
Interesting.
I think maybe she's talking about some fistulas with worms or something like that. So unless we examine, we won't be able to guide on this. But yes, worm infestation. So the point you mentioned here was worm infestation. Can worm infestation may cause irritation?
Irritation, but not
won't cause
UTI.
UTI. Any other?
Is there any role of toilet training in prevention of the primary enuresis?
So sometimes the child has primary enuresis, but then later on also develops some voiding difficulty, constipation. So that when you don't address that primary enuresis, the resolution of that primary enuresis will become an issue.
But I didn't get the question.
No,
Usually
is
we
there any
expect
role
that.
of toilet training?
You mean early toilet
Early-
training?
early
Because by
toilet
5
training,
years we expect the children
Yeah,
to be
yeah.
toilet.
Early toilet training has any role in prevention
No.
or early toilet training exaggeration of the enuresis? No.
No.
So there were some studies where they had shown that
Early toilet training is associated with-
Yeah, training them early
6
was
to 9 months is
associated.
associated with
But
that.
then it's not proven per se.
This is not under control. Brain is not controlling. That is the training should
Yeah.
not help.
Yeah, it doesn't.
He is not doing it
yes,
purposely.
Yes. It has not been
Yeah, so
shown
it's
by
not
them.
that psychological
Yes.
issue or
It's a bladder
being
brain
extremely
discorrelation is not
strict
there.
with the child and forcing toilet training and all, so it is not sure. On the other hand, they say that you should initiate toilet training by at least 6 to 9 months.
That's the normal
That's the
time when
normal.
we should ask them to kind of start training.
Start.
At what age?
What age?
Like by 9 to 10 months,
9
like
months should
usually
have-
we have seen that children here, infants, not toilet trained, not for the voiding, but at least for stool pattern, we have seen that they ask the children to stand and pass stool. So that should be avoided. You have to, since that time you have to kind of, when they start becoming 1 year of age, they have started walking, to use a potty, the seat, potty seat to sit and then pass stool. Because passing stool in standing position, right from start, that kind of becomes habitual and then that will predispose them to constipation. So for that thing, it is advisable. Once they start walking.
One question about urinary specific gravity. Can it
Any role?
direct ourselves to certain treatment like desmopressin or like that?
So one thing is, what specific gravity is given in the lab should not be relied upon because it's done after some time. Ideally, for specific gravity, you need a osmometer, which we do have it at our clinic, but you can actually check it bedside. And if it is really less, then you should think of other causes. That why should urine osmolarity be less in a child? Ideally, they should be able to concentrate the urine. So the specific gravity should be 1.010 to 1.05.
For urine routine, whether early morning sample or any routine sample
So
is okay.
urine routine, you can give any
Any
sample. Yes.
How much delay is acceptable and collection of sample until processing?
For the
At
Urine
what?
routine?
Yes.
So ideally, it should be done immediately, but it can be done within 24 hours if it's kept at room temperature. Culture, if it's not incubated immediately, then it's advisable to be refrigerated to prevent the natural bacterial growth if you are keeping it at normal room temperature.
One question, madam, other than this topic, how will you counsel a parent of a newborn who has been labeled to have a certain amount of pylectasis in ANCUH, the 5 mm or 6 mm, and it continues like that at 1 month of age also?
Okay, so that's, I think, a different topic altogether,
It is
but just to
common.
answer this question, so APD diameter, if it is more than 10 millimeter, then you have to kind of act then and there. But if it is less than 10 millimeter, but if it is bilateral pylectasis, you keep a close watch. Like you do a USG at 3 months, you do a USG at 6 months. And if it is not associated with other abnormalities like thickened bladder wall or significant post-void residue. But let's say if you are getting some pylectasis
On top of that, you are getting some bladder wall thickness. Again, it should kind of decrease your threshold of investigating the child further. And especially, let's say if the child has UTI, then so definitely you will have to investigate. Because one thing which we have observed is USG is a very subjective kind of thing. So many a times, one sonologist might not report something which you might be reported later in another sonograph.
Just now we had one case from Singhal. This was one of my patients. Just this child had bilateral pilectasis, and it was like this only 10 to 15 mm bilateral. Child was clinically doing good and everything. Just today that mother came to me. They were showing to Shrodriyasar, and he has followed up 3 months. Now child is 6 months, and today for a surprise that mother has shown me MCU. I was surprised that sonography did not show any major abnormalities, but MCU showed grade 4 reflux in one kidney. So it was a totally twist for me. So that is something which happens. Most of us feel 10 to 12 bilateral should resolve, so let us just follow. But MCU is one of the very important things. Sometimes sonography may not pick up, but MCU is something which should be done. And then for me it was a surprise. Now this child is going to be posted for surgery. So grade 4 reflux, I was also not expecting. And this is what happens.
And maybe sonologist machines, does it matter?
I think it's the skill of the sonologist.
Who advised the MCU?
Chaudhary sir. So it was referred to pediatric surgeon at the earliest. Since it was a bilateral one, I said please go as early as possible. Baby was delivered in Sanigurji, and otherwise very well-to-do baby, no issues. But antenatal sonography itself showed this bilateral pilectasis. It was initially 10 mm which progressed to 15 mm. So I told them this doesn't look to be normal. We'll have to closely follow. First you go and meet sir. Today they came for 6 months follow, and then I noticed that MC was showing grade 4 VUR on one side, unilateral. Thank you so much for today's presentation. We are very happy to have discussion on this very important and very crucial topic. So